everyone, welcome back to my channel. I'm Hannah and this week it is Crohn's and Colitis Awareness Week and I have ulcerative colitis. But what the hell is the difference between Crohn's and colitis? They are both forms of inflammatory bowel disease, so obviously there are some similarities, but there are also some differences. So what are they? In the UK, ulcerative colitis affects about 1 in every 420 people, and Crohn's disease affects about 1 in every 650 people. So it's highly likely that you know someone or have met someone, a friend, relative, colleague, someone you went to school with who has some form of IBD. In the UK, as well as specialist consultants who will be able to diagnose and treat you, there are also specialist IBD nurses who are brilliant. As someone with IBD, your IBD nurse is usually your point of contact at the hospital. There is usually an advice line, a phone number, or an email where you can directly talk to them. So if you have any questions or are experiencing any symptoms or are in a flare and you need to talk to someone at the hospital, they are there and can talk you through things, get you in for an appointment sooner if necessary, and just generally help you out. They are really knowledgeable and just brilliant at talking to patients and supporting them through everything. The charity Crohn's and Colitis UK kindly set me up with IBD nurse Fiona, and she came around and we did some filming all about the differences between Crohn's and colitis. So I'm joined by Fiona.
So hi, I'm Fiona. I'm an IBD nurse from St George's Hospital in South London.
Thanks so much for
It's my pleasure.
coming here and sharing your wisdom and knowledge. First off, what is Crohn's? What is colitis?
So ulcerative colitis is an inflammatory bowel disease that affects the large bowel, the colon, from the rectum all the way around your large bowel. Crohn's disease is an inflammatory bowel disease that can affect anywhere from the mouth to the anus. IBD nurses play a pivotal role in the patient's pathway. I run clinics, face-to-face, telephone clinics, and we run an IBD advice line. So as an IBD nurse, we can help support and talk you through your diagnosis, particularly if it's a new diagnosis, but anywhere throughout your patient journey. We get more time than the doctors to chat to you in clinic, and also we'll pop up and see you on the ward if you're unfortunate enough to be an inpatient, just to give you that time and support.
Yeah, oh my God, being able to call my IBD nurse has been just so useful over the years.
Definitely.
Just knowing that you have that point of contact in a hospital, rather than being oh, now I have to make an appointment at my GP and then be referred again. You already have that direct line. So we're gonna play a little game. What's the difference between Crohn's and colitis? And we're gonna go through different things about the disease, the symptoms, and different treatments that are available. And I have created these paddles. It's a game show. So the first section is what actually is the disease? What is going on? So it's a chronic lifelong condition. Both! Yay! I mean, it's not great news.
Not great news at all. It's lifelong. There is no cure, but it doesn't, you should be able to lead your full potential in life.
My second point was it occurs in remission and flares. Yeah! That basically means that sometimes you might be having symptoms and then other times you're not at all. So next thing is it's a result of inflammation. Both of them! Yeah. So what is inflammation? But then also there is a slight difference in how it occurs in both of these.
Yeah. So both are autoimmune diseases that your immune system has just gone a bit wonky. It's berserk. It doesn't know how to turn itself off. So it's gone into overdrive and creates inflammation. And the more inflammation that there is, it's just kind of a vicious circle. The inflammation that you see in colitis usually starts or always starts in the rectum, and then is continuous as it works up the colon. Mm-hmm. So it's in your, I need a sort of picture here, I feel, but it's in your colon and then works around the U-bend, which is called the sigmoid.
Ah, okay. So that's why it's called a flexible sigmoidoscopy. Okay.
So that's sort of looking at the left-hand side of your bowel. So rectum, around the corner through the sigmoid, and then up your descending colon. Mm-hmm. And then So that's what they term, if it's just what you may have heard a term proctitis.
Yes.
So that is disease, ulcerative colitis in your rectum.
So I currently have proctitis because I have my rectum
You have
remaining.
the rectum.
Yeah.
Yeah. So, and you've got active disease in your rectum?
Yeah.
Okay, so that's proctitis.
I'm like, as if I'm proud of that. Like, yeah, I have active disease in my rectum.
Joy.
Yeah.
So if you still had your colon,
Yeah.
past the rectum is the sigmoid. So that's proctosigmoiditis if you had disease in those two areas.
Ah.
If then it extends up the descending colon, it's descending because it's coming out, but up that way, that's left-sided disease. You might hear that term bandied about in clinics. Left-sided disease or proximal disease, you might also hear it called. If it keeps extending, the inflammation, it will cross the transverse colon. And if it gets to that extent, it's termed extensive colitis or pancolitis.
I had pancolitis. That's what I recognise that term.
Yeah.
Yeah, that's what it was called for me.
So you can get inflammation all the way through your colon,
Yeah.
and that's extensive colitis. But that's where it stops with colitis.
Yeah.
With Crohn's, you can get inflammation anywhere from your mouth to your bum, but it's not continuous in its course. So you could have proctitis in Crohn's, but then you could have a healthy colon and just have a patch in your terminal ileum, which is the sort of join to the small bowel. And then you could have patches throughout your small bowel. You could have a patch in your mouth, a patch in your esophagus. So
Does it affect the stomach?
Yeah, it can affect
okay.
anywhere in your GI tract from your mouth to your bum.
Ah. Yeah, and like you said, it's not continuous, so it could be like healthy bit and
Yeah.
then inflamed bit. Da, da, da.
Yeah.
But in colitis, you can't, even if it is just in the large bowel, you couldn't have like your rectum has some and then a bit up here has some.
No, it's always continuous.
Okay.
And extending. So extends from the rectum and always continuous inflammation.
It creates ulcers.
Yeah, it do.
Yeah. So I didn't realise that this was also relevant to Crohn's, because obviously colitis is called ulcerative colitis, so it's in the name.
So it forms ulcers in your colon is what ulcerative colitis is doing. So the difference is that ulcerative colitis only affects the inner inner lining of your colon.
Yeah.
Whereas Crohn's disease affects all the linings of your bowel wall. So it's called transmural. If you get colitis that causes ulcers, those ulcers will form in the inner lining of the bowel wall. They're horrible. They can be quite deep ulcers, and they're prone to bleeding, which is why you would get bloody diarrhea. In Crohn's, it's also ulcer forming, but it can, if it penetrates the bowel wall, then it can cause a hole, cause a fistula, lots of sort of complications. You can get abscess formation. It's inside, yeah. There's a small percentage of people where actually it's difficult to tell what you've got. So the way they would do it is do a colonoscopy and take some biopsies, and under the microscope they can differentiate between what's Crohn's and what's ulcerative colitis.
Okay.
Which is then easier to treat your disease.
And we will get onto treatment in a bit. But first, symptoms. This is the best part. Diarrhea.
Oh.
Yeah.
Yeah. Not always with Crohn's disease.
I guess it depends where it is. Yeah.
But I would say
colitis.
Yeah.
100%.
Yeah.
Blood and mucus in stools.
Okay, both. But I would predominantly. Have I gotten the right way around? Yeah.
Yes.
Predominantly. Ulcerative colitis,
Yeah.
you'll get bloody stools.
Increased frequency and urgency to go to the toilet.
So both. I don't want to get this wrong, but I think I would probably say slightly more in colitis. Definitely urgency and frequency in a UC flare is really, really common. It is also common in Crohn's, but I would probably put it out there as a symptom, slightly more in colitis.
Okay, next symptom, vomiting.
So predominantly Crohn's. If you have a flare and you're feeling really crap, you could potentially vomit with
because that was me.
colitis. Yeah. So if you're really, acutely unwell, this is possible. But I would say more common to have to have vomiting in Crohn's disease, particularly if you had a blockage in your bowel. That would cause...
Oh, yeah. Abdominal pain.
Definitely both.
Oh, God, yeah.
Definitely both.
Loss of appetite.
Definitely both, yeah. I mean, it's your GI tract, isn't it? Its function is for you to eat and get the food and nutrients in. And if your bowel is in flare and angry and inflamed, you're not going to want to eat, really.
And also just when you're ill in general, like, not fun. Weight loss?
Both. For the same reason that you might just have a decreased appetite.
And you're just passing stuff out constantly.
Yeah, for sure. Yeah, definitely.
Tiredness and fatigue.
Oh, huge on both.
I was talking to some friends recently and they were discussing like how they used to be like in their early 20s or at uni with like the extreme lack of sleep and everything. And I was like, I wasn't like that. I like often didn't go out because I needed sleep.
Yeah.
And I've always known that I've like needed more sleep than my peers.
Yeah.
But I just thought that was like how I was.
Yeah.
And then someone on like Twitter was just like, that might be because of your colitis, even though I was well during that time. I was like, maybe.
Yeah.
Feeling generally unwell.
Yes, both.
And anemia.
Also both. If you've got active disease, your bowel is unhappy with some bleeding in, you're more prone to anemia. And
because of the loss of blood. Yeah. And then would that also like contribute to the tiredness and the fatigue as well?
Absolutely.
So it kind of all like feeds into each other, I guess. Okay, so now on to treatments.
Okay.
There's a lot of treatments out there. Steroids. Ding, ding, ding. Yes.
So steroids are, so the gold standard of treatment is to have steroid-free remission, but steroids have such a good place in IBD.
Because they're anti-inflammatories.
They are, yeah. So if you have either and you're in flare, in pain, frequency, diarrhea, a course of steroids is like your get out of jail free card. Mm-hmm. But 2 or more courses within a year, we would look to escalate treatment for both.
Oh, really?
Yeah.
Oh, okay.
Then, they're a fab drug, but they do have horrible side effects used long term.
Oh, mesalazines.
Okay, so colitis, but there will still be some patients on mesalazines for Crohn's disease. But more recently, the evidence is that it's less effective in Crohn's disease.
Okay, so what are mesalazines?
Mesalazines are, so if you have a rash on your skin, you would put some cream on. Mm-hmm. So this is how I interpret it. It's a bit like an internal cream for the lining of your bowel wall. So really kind of relatively safe medication to take. Just a yearly blood test to check it's flushing through your kidneys okay. But you can take an oral tablet. You can also take rectal treatments. I always do that.
Rectal treatment. But that's what it is. That's what you do.
Is. So you can have a suppository, or you can have a foam enema.
Oh, so the enemas are mesalazines.
You can have steroid enemas. Oh, we didn't mention that. You can have steroid enemas or you can have mesalazine enemas.
Yeah.
But first, actually, mesalazine enemas are thought to be more effective than steroid enemas. So we'll try those first in ulcerative colitis.
Liquid diet.
We've got our first solo.
Crohn's.
Liquid diet is used, it's hard. They use liquid diet a lot in children because you can be more strict with children as to what they put in their mouths. But it's an exclusive, call it enteral feeding. So an exclusive liquid diet. So you're basically giving your bowel a bit of a break by not having to break down food. Okay. It's already liquid. You can absorb the nutrients more easily in a sort of angry bowel.
Immunosuppressants.
Oh.
Dun, 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 dun. Yeah, because it's an autoimmune disease, so
your immune system has gone berserk, just doesn't know how to turn itself off. So by suppressing your immune system, it sort of tricks your brain into going, can chill out, turn myself off, and job done.
Biologics.
For both.
Yes. So what are biologics?
Biologics are another immunomodulating drug. Mm-hmm. So will suppress your immune system, but they're just a bit cleverer than azathioprine. So there are several. So drugs that you might have heard of, like infliximab, adalimumab, vedolizumab.
All of the mAbs.
And
it's administered IV as well. It's like
so different. So the first line biologic that you would have for either of these would be infliximab or adalimumab. So infliximab is a drip. So you would come in for an infusion. I said infusion once, and the patient was like, "What, like tea?" No.
I've always called them infusions, though.
Yeah. But Humira or adalimumab, Humira is a brand name. Adalimumab is a subcut injection that into the fat of your thigh or your belly, a bit like an EpiPen.
Okay.
So
this one I'm not aware of.
Okay. It's quite popular because you're in the driving seat. You have the drug at home. It's really quick. Yeah. Just pinch up a bit of skin, jab it in, and you do that every other week.
And so the way the biologics work, because it's kind of in the name, and it's an immunosuppressant, but it's like putting antibodies in your
So
when I first had it, and it was like all new, I was 15, and a friend of mine, she wanted to become a doctor. She now is a doctor.
Okay.
But she was like nerding out about the whole thing, and she was like, they're putting mouse genes in your body, Hannah.
Okay, so infliximab is mouse derived, but Humira or adalimumab, Humira human, is the human form. But they're both really similar in their makeup of drugs. God, we need your friend here with her nerdiness. But generally, put simply for me, when you have inflammation, your body produces a protein called TNF, and infliximab, adalimumab are anti-TNFs. So you flood your body with anti-TNFs and it blocks the TNF, so thereby reducing inflammation.
Antibiotics.
Crohn's. So
why?
Why? Because Crohn's can, if Crohn's breaks through your bowel wall, you can get abscess formation and it can cause fistulas, which can cause infection. So the antibiotics are caused to reduce or to clear up infection.
Surgery.
For both.
Yes.
So there's for colitis, you are a shining example of.
You can have your colon removed.
And so that's your main surgery for colitis, having your colon removed. In essence, if you've got rid of your colon, then are you cured?
Yeah, some people do say that it is a cure for colitis. Obviously, I'm not cured yet because I still have my rectum, but I could potentially have that removed in the future.
So you can have what they call a total colectomy, where they take out the whole colon, including the rectum, or a subtotal colectomy, which is what you've had, where they leave your rectum in. And Crohn's, there's sort of multiple surgeries that you can have. Because it's not continuous in its inflammation, if you've got small areas of inflammation throughout your bowel, if one area becomes so narrowed and stenosed and causes a blockage, that would need to be removed.
Oh, okay. And then the final thing in terms of the difference between the two is diet. So which one is diet more connected to? So
everyone's individual. And I would say diet plays a bigger part with Crohn's disease, although it does play a part in colitis as well, particularly if you're in flare. The only time a healthcare professional will tell you to eat more processed food, white rice, white bread, pappy processed food.
Love it.
Go wild. And Crohn's disease, everyone will find their triggers though. Some people, no matter what the evidence says, that diet doesn't really make much difference to trigger a flare. There will be people that say, actually, I have found that this does trigger a flare.
Yeah.
But Crohn's disease, if you have active Crohn's disease, diet can really help improve your symptoms. And it may be that you're referred to a dietitian to support you through things like using a low FODMAP diet. But in general, we'd say a low residue diet if you have active disease for either.
Fantastic. So thank you so much for watching this video. I hope that you have learned something. I have certainly learned a few new things about IBD. Please do give this video a thumbs up if you enjoyed it and you liked my arts and crafts. This is just a pencil stuck to the back of these. And I'm going to leave some links in the description to where you can find out more info about Crohn's and colitis, as it is Awareness Week. Thanks again for watching, and don't forget to subscribe and hit that notification bell because I make new videos every week. And now I'm just going to fan myself. Thanks for watching. Bye.